Hi, my name is Sarah. I'm the student nurse today, and I will be performing a newborn assessment on a baby who was 39 weeks gestation delivered, and he's 7 pounds, 20 inches, with an Apgar score of 8 and 9. He has voided right after his delivery, and I'm just going to grab some supplies, also make sure I check hospital policy, refer back to my handbook if I have any questions or concerns. I will be checking newborn vital signs as well. So before I go in the room, I'm going to do hand hygiene out here, provide patient privacy, and I will also be wearing gloves, and I will don on gloves. So first thing first, I'm just going to do a general assessment on the baby, just by looking at the baby, and I could also take him out as well. I want to check his MRN number, make sure that I have the correct name to the correct patient's room or to the correct nursery bed, making sure that this is the right patient for my mom who just delivered. So I will check the armband and the MRN number, birthday, name, and I will compare it to my chart to make sure that I have the right patient and I'm doing the right assessment on the patient. So in the beginning, when you assess the baby, you're just going to do a general assessment. You want to look at just the baby. Is he sleeping? Is he quiet, alert, crying? And when he does cry, you could just note the type of cry that he has. Is it high pitched, which can indicate that the baby is in respiratory distress or has increased cranial pressure, increased intracranial pressure. But I'm also just going to assess for the skin color of the baby, if the baby's lips and mucous membranes are is dry, and I will just note the fingernails as well. If he is cyanotic, he might have acrocyanosis for the first few days after birth. But if anything is abnormal from the last time I saw him, I would note right away. So after the general assessment, I could also just turn him around, look for any birthmarks. Look for any birthmarks, any vernix. If he still has some, I could clean him off or see when his last bath was. And usually we give a bath before the patient gets discharged, and we could teach the mom as well. And then see if there's any lanugo on his back, the hairs on his back, see if there's any sacral dimples, or if there's any curvatures. I'm just doing a general fast assessment, but I will note any magnolia spots or birthmarks so that I could tell, so I could chart it, because oftentimes it could be mistaken for, it could be mistaken as like a bruise mark or like some type of child abuse. But I just want to note that the baby is pink and that there is no cyanosis noted. So after my general assessment on the baby, I will want to take vital signs. So I will assess first the baby's respiratory rate, his effort for grunting, which can also be like a sign of an infection or a heart defect. And I will just look at his rhythm, because in the beginning, after they are born, they may have irregular rhythms. But I will be sure to assess for increased breathing pattern, and if anything has changed, such as apnea, which may, or just an increased respiratory rate of tachypnea, which can indicate that the baby is hypoglycemic due to poor nutrition, or just due to like the baby not feeding very well. Just due to the baby not feeding very well, maybe due to heart conditions, so that could cause the baby to go in hypoglycemia, or the mom may have gestational diabetes, so maybe the mom was taking too much insulin. But yeah, I will just count the respiratory rate for a full minute, but the normal respiratory rate for a baby will be 30 to 60. Baby's respiratory rate, I will count for a minute, and baby's respiratory rate is currently 50. I will then auscultate the heart, and I will also listen to the heart, which is included in the vital signs, for a full minute. So I'm going to use the smaller part of my stethoscope, and I'll push over here and listen for the heart. A normal baby's heart rate is between 110 to 160. I will note for any murmurs or gallops, rubs, um, and I will make sure to chart that as well. I will now listen for his lung sounds. And then I'll listen to the back. Okay, I will note if I hear any crackles or any abnormal sounds as well. So after finishing the general assessment and taking vitals, or just, no, I haven't finished the temperature yet, but after just looking at the general assessment, I'm going to be observing for any abnormalities. So if there's any crackles, I would chart that due to maybe inhalation that the baby may have experienced of the amniotic fluid or meconium right after birth. And I have assessed the heart, made sure that it's within normal limits, and then I will take the temperature. So this is my thermometer, and I will place the thermometer right under the baby's armpit. And a normal reading for the temperature should be between 97.7 degrees Fahrenheit and 99 degrees Fahrenheit. This baby's temp was 97, which may just be due to, 97, which may be due to just not keeping the baby warm, maybe not enough skin to skin contact, but babies do tend to be hypothermic if they aren't cleaned off right away, if they don't have, if they're by a draft, like they could get cold really easily after birth. So it's important to just always dry your patient after delivery. Make sure that the baby does get skin to skin contact with mom, because that does help the baby get warm as well. So now that I've done a general assessment and vital signs, I will be doing my head to toe assessment. So for the head, I will just be observing for the symmetry. I could feel through here and assess for the fontanelles. And then I will be just noting that the head is 1/4 of the size of the baby's body. I will run my hands over, feel for the suture lines as well, and I will note and chart if there's any cephalohematoma. But I want to teach the patient that if there is, like, it's totally normal and it will go away within around 6 weeks. Yeah, so what happens is that molding happens and the baby, the sutures have molded, and the baby will come out with something known as a cone head. But after that, after doing the head assessment, I'm just going to feel for the fontanelles, make sure that they're both there. The anterior fontanelle should be soft and flat and diamond, whereas the posterior will be a little bit triangular, and that one will close first. I could teach that to the mom. So after that, I will just assess the eyes for symmetry and if they're clear. And then I will use my pen light. Hopefully the baby's eyes will be open, but I could check the baby's eyes, making sure that the pupils are equally round and reactive to light. And I will look for the red light reflex. So absence of the red light reflex could actually indicate cataracts or any eye disorders, and which you would want to let the provider know. But the eyes may appear a little swollen and have edema to it, but that is an expected finding, and that's okay the first few days. But I will just chart the shape of the eyes and the positioning of the eyes, and I'll just observe for any abnormal discharges, excessive redness. If there's any signs of infection, I will just make sure to note that and chart it, because you don't want the baby to have an eye infection. And then next, I will go to the ears. I will assess the ears and see that the ears should line up with the eyes. But if the ears do tend to be lower, it could be a congenital abnormality indicating Down syndrome. So you'll have to make sure that everything lines up, and you want to chart the shape of the ears, the placement, and just the symmetry of the ears. So for the baby's nose, babies are nose breathers. So you want to make sure that the nose is patent and free from any occlusion. Maybe that could still be in there from childbirth, from the birthing process, I mean. And the nose will typically lie in the middle, midline. It will be flat as well and a little bit broad. But noses should not be flaring, which is when they open up their nostrils to get more oxygen. But that is a sign of respiratory distress. So a way to check if the nose is occluded is that you want to just push down one and then see if they're breathing. And then you push down the other, see if they're breathing as well. And then the nose is patent and clear. After assessing the nose, you'd want to assess the newborn's mouth. You want maybe they will cry. You could always just look inside, make sure that the mouth and the mucous membranes are pink and moist, meaning that the baby is hydrated well enough. And then you can also place a gloved finger inside the baby's mouth. And then as you do that, you could feel if they have a cleft palate. Because sometimes it is harder to see if there is a cleft palate in newborn babies. But while you're checking the cleft palate, they will start to suck your finger. And there you go. You just finished the sucking reflex. And then I will also check for the rooting reflex. I will run my fingers down the side of the face, and the baby will turn their head that way. And that is called the rooting reflex, which is a good normal reflex for the baby to have. All right, so after checking the mouth, I can also assess the tongue while the baby's crying. I will assess for the movement of the tongue, making sure that the baby is not tongue-tied, which can cause complications in breastfeeding. But it's important to just assess the movement, symmetry of the tongue when the baby does cry. All right, now I'll assess the neck. I could palpate the neck, making sure that the trachea is midline, and just making sure that the neck will typically come out short and thick with a trachea midline, like I just said. All right, now that I've done with the head and neck, I will do the chest. So I will just assess the shape, symmetry, movement, and also I will look at the ribs for any retractions, because that may mean that the baby is in respiratory distress. So I will also note that the chest and abdomen will rise and fall in synchrony, and the nipple prominence is has a little bit of edema to it and will be like a little bit swollen looking, but the placement should be symmetrical. Next, I will auscultate his little abdomen. So I will auscultate the bowel sounds in all 4 quadrants. I will note if bowel sounds are present. Bowel sounds may not be present until maybe a few hours after birth, and that is normal. But I would want to assess for any distension. If there's any mass, I could palpate. And then I will just palpate the umbilical cord, assess the umbilical cord for any inflammation, odor, redness, draining that can indicate that there is an infection. So you'd want to tuck your diaper beneath the umbilical cord, and you want to teach your mom that as well. Never pull or tug on the umbilical cord, and because you don't want to rip it out, because that could really hurt the baby as well. So after doing the belly, auscultating, assessing, and palpating the baby's belly and abdomen, I will move on to his extremities. So in his extremities, I will assess for any yellowing or signs of jaundice, but acrocyanosis is expected, which can last up to 48 hours, which is when his extremities are a little bluish. Excuse me. I will then palpate his clavicles, his shoulder, his joints, elbows, wrists, and fingers, assessing for any fractures or traumas that could have happened during childbirth, because shoulder dystocia can happen if the mom's passageway was too small. And then I will assess his extremities, making sure that he has all 5 on each hand, all 5 on each leg, each foot. Because a common finding is that they will have an extra digit or an extra finger, so I will want to make sure I count all of them. Then I will also palpate the femoral pulse, feeling for equal, strong, and bilateral pulses. And then I could also palpate the brachial pulse, feeling for the same thing, just assessing the circulation within the body for the symmetry, strength, and rhythm. So limbs typically will be flexed and symmetrical as well. I will be assessing that and charting that. And while I'm just here on his arms, I'm going to just assess his palmar grasp. So I'm going to put my fingers here, and they will curl their fingers over my hand, over my finger, and that means that they have passed the palmar grasp reflex. And then at the feet, I could also check for the plantar grasp. So I could press my finger against his on the bottom of his feet, and his feet will curl down just like this. And then I will assess for the Babinski sign. So I'll stroke the outer edge of the baby's foot, and then the feet will just flare. And that's a normal sign for babies, for newborns. But after that, his extremities are looking just normal. He's flexed. They're symmetrical. He has all of his little fingers. So everything looks good. Next, I will move on to his genitals. So for female babies, the labia may be swollen, and I will also want to take off the diaper for this, of course. So the labia for the female babies will be a little bit swollen. The clitoris may be enlarged as well. And if you do note any signs of discharge, that is known as smegma, which is a totally normal sign. And also for females, you can also see pseudo menstruation, which is where there will be a little bit of blood in the diapers due to the mom's hormones circulating through the baby. And this is expected in the first few days of life. So, onto the genitals. So, onto the male genitals. I will note also for male and females, you might also see a dark reddish urine here, which may indicate that in the diaper, which may just indicate urate crystals, which is due to really concentrated urine. But after that, so for in male patients, it's a little different. So their scrotum will be a little swollen, but you want to make sure you palpate the testes. Make sure that they have descended, and you'll feel like two little tiny marbles, or it'll just feel like marbles. Just make sure that they are descended, so palpate them. It's really important to verify that the meatus, where the urine comes out, that the meatus is at the top of the penis and not on the side, not on the bottom, because that is a complication, and you would need intervening for that, and you let the healthcare provider know if the meatus is on the side. You may also see concentrated urine. Oh, I already said that. So after that, I will be assessing the anal. I will assess the anal opening. I will assess for the first meconium stool, which the baby already had. And it will look like green black tar-like, and it's very sticky, and that's normal within the first few days, the first few bowel movements. But I will ask the mom how many times has he had a bowel movement, noting his frequency, noting the characteristics of his stool. And then after assessing his perineum area, I will move onto the baby's back. So on the baby's back, I will assess for straight curvature. I will perform the Gallant reflex test by stimulating the side of his spine. So it will go like this, and the baby will flex towards that way, just like that. In addition, I'll be looking for hair tufts and dimples along the spinal column, which can indicate that he does have a spinal disorder. But I will also look for, like birthing marks to note and chart, just so that the parents do not think that it was abuse. I will perform the remaining reflexes, which include the stepping reflex. So if you place the baby like this on a flat surface, the baby will start to step, like make little stepping movements. And then I will do the startle reflex. So startle reflex or the Morrill reflex is when a loud noise occurs or the baby may be startled. So the hands will throw out the arms like that, and the baby's head will throw back like that. So after that, I will just be assessing the baby's I think that's all of the reflexes. So the baby will be like that, and that is also a good normal sign. After this, I have done my general assessment. I'm looking at the baby's demeanor. He seems really pleasant, no signs of respiratory distress, and he seems like he's just enjoying his new life. So I'm going to show you how to swaddle a baby. You want to tuck the arms in, and then you want to tuck this arm in as well. And then I fold it from up here, tuck it in his shoulders. I bring this side over here, and then I'll bring this side over here and make sure I tuck that in. You'd want to teach the mom how to swaddle her baby so that the baby feels comfortable and tight, just like how the baby would be in when the baby's first born. And tuck that in, and there you go. He's happily tucked in and swaddled and comfortable now. I will document my findings and I will maintain patient confidentiality, making sure that I know all abnormalities that I did find if I found any. But baby looks healthy, and thank you so much for just going through this with me and watching me perform a newborn assessment. Bye.